sprains a day in the US. Imagine what that does to aircraft sales. 90 to 95% of ankle sprains involve the lateral ligaments, and the medial ligament injury is rare, and it usually involves the lateral ligaments as well. 25% of injuries in every running or jumping sport are ankle sprains. And the mechanism of injury is usually an inversion and plantar flexion of the foot when landing off balance or gripping another player's foot. Here are the diagrams of the ankle. As you can see, the ligaments that are circled in red are the ones that are commonly injured. And in the case of the lateral ligaments of the ankle, these are the anterior talofibular ligaments, the calcaneofibular ligaments. Also pay attention to the bifurcated ligament, which I will be speaking about also briefly. And above it is also this anterior tibiofibular ligament, which is part of the syndesmotic ligament, which I will touch on as well. The sequence of injury in the ankle sprain is usually, first of all, the anterior talofibular ligament gets injured, followed by the calcaneofibular ligament, and if the injury is more severe, the posterior talofibular ligament will be involved. Some diagnostic tests will need to be done. In the clinic, you can examine the patient and palpate the areas of tenderness. Do the anterior draw test, and as I will show afterwards, the external rotation test. If you have available, do x-rays, and better still, stress x-rays, putting the patient in inversion stress to see whether there are any signs of subluxation of the ankle joint. Where indicated, the patient has to be sent for an MRI scan. This is how you do an anterior draw test. You place the patient on the table in front of you, and you sit down and hold the lower leg just above the ankle with one hand, and use the other hand grasping the heel to try and draw the ankle forward. This is to test for stability of the ankle joint. A high ankle sprain is important to exclude. The reason we have to make sure that we do not miss a high ankle sprain is that the treatment is a bit more complicated and more prolonged than an ankle sprain. This high ankle sprain happens typically when the tibia and the leg rotate inwards while the foot rotates outwards. Clinically, you examine the patient by doing a squeeze test, squeezing the tibia and the fibula as shown, and see whether that brings on pain. Alternatively, you can do an external rotation test where you try to externally rotate the foot while holding onto the tibia. This test will also cause pain if the patient has a high ankle sprain. The bulk of treatment is actually physiotherapy. In the acute phase for ankle sprain during the first 72 hours, you start off with rest ice compression and elevation. Later on, you add in an ankle brace, you continue to use ice, and as what this workshop is about, you get the patient to undergo good functional rehabilitation. Surgery is indicated only if there is chronic instability with no improvement in spite of physiotherapy, and by that I mean typically at least a few months of regular physiotherapy, or in the case of high-performance individuals with a severe and unstable high ankle sprain. In the case of a surgical procedure, what we would normally do is we would actually repair the ligaments of the lateral ligaments that have been injured, and for a high ankle sprain, sometimes you have to put in a screw to stabilize the distal tibiofibular joint. Next is the bifurcated ligament. As you can see in this diagram, the bifurcated ligament is located at the anterior process of the calcaneum, and it consists of two ligaments that branch out. That's why it's called a bifurcated ligament. It is useful to learn how to locate it with your thumb and two fingers. What you do is place your thumb on the lateral malleolus and the middle finger on the fifth metatarsal. Where your index finger comes to rest naturally is where the bifurcated ligament is located. And any pain and tenderness in that exact region will make you suspect that the patient has bifurcated ligament. This is driven from a lateral ligament injury where the pain and tenderness will be felt more proximally nearer to the tip of the fibula. The treatment in this case is very similar to that of an ankle sprain. It consists mainly of rest and some functional rehabilitation. Next, we have Achilles tendinopathy. This term, tendinopathy, came about because in the past it was thought that it was a form of tendinitis, which implies inflammation. But further histological research showed that it was actually a form of degeneration, and that any anti-inflammatory medications were actually ineffective in the treatment of such conditions. There is a process of tendon degeneration in a zone of relative avascularity above the incision of the Achilles tendon into the calcaneum. So patients with these symptoms will present with morning pain, pain at the back of the heel that increases with activity, intermittent swelling, pain after a day's exercise. And there is usually thickening of the tendon. And you can tell, because if you palpated the patient's tendon, compare that with the size of the little finger. The patient's little finger represents the size of his normal tendon. If the tendon feels larger than that, chances are he has a swollen Achilles tendon. So also the treatment is predominantly physiotherapy. You ask them to do eccentric moving exercises, and it may be expected that it takes months of persistent effort. There are many other treatment modalities available, but few are backed by evidence. A small minority of patients will benefit from injections in the tendon sheath or an endoscopic tendon revival. Normally, before we go to this stage, we will have to at least do an MRI scan to confirm the diagnosis, and this is an example of how it will look. You can observe the fusiform swelling of the Achilles tendon here. An Achilles tendon rupture is a more serious injury. It is the result of sudden ankle dorsiflexion beyond the neutral position. The patients will say that they think they got kicked from behind, and it is estimated that 20% of such cases are missed at the first medical consultation, and this results in late presentation of the patient. In the old days, before MRIs were widely available, we were taught to do what's called the Thompson test. By squeezing the calf muscle, you will cause the Achilles tendon to contract, and if you see plantar flexion of the foot, you know that the Achilles tendon is intact. But if there is absence of plantar flexion of the foot, then you are very sure that the Achilles tendon has been ruptured. Of course, nowadays things are much easier, and with an MRI scan, as you can see here, it clearly shows that the Achilles tendon has ruptured. This is a potentially life-changing injury, but especially for active individuals, and worse so if it is not optimized, if the treatment is not optimized. Different patient circumstances dictate treatment options. For example, the age, whether there's any coexisting illness, the patient's lifestyle, and whether it comes with an early or late presentation. Non-surgical treatment, when indicated, is optimum, but it has to be started within 24 hours of injury. Surgical treatment can depend on whether it is an early presentation, a surgical repair would be the choice. A late presentation will usually require tendon transfer and reconstruction. It is known that there is a long period of recovery due to unavoidable muscle atrophy, and it is worsened by suboptimal rehabilitation. These are some of the usual accessories or tools I use to treat patients with an Achilles tendon. Here is the very commonly available, widely available air cast foam walker, and we use that in combination with this styrofoam wedges to elevate the heel. Recently at an international conference, Professor James Calder from London again emphasized the importance of rehabilitation, because he too found in his research that patients did well only if the rehabilitation for Achilles tendon injuries was well and properly was comprehensively done. Sometimes in the clinic, you will see a patient presenting with a bulge in the heel like this. This is typical of a condition called retrocalcaneal fasciitis, because what has happened is that the bursa between the Achilles tendon and the calcaneum has swollen and become inflamed. This pain is brought on, and pain is brought on by activities that dorsiflex the ankle as TA impinges against the inflamed bursa. My preferred treatment for these cases would be to actually put ice or anti-inflammatory gels over the swollen area, do calf stretching, and advise the patients to walk with smaller steps and avoid dorsiflexion of the ankle. Plantar fasciitis is a condition I'm sure most of you see every day in their practice. And a lot has been said, but I would like to emphasize what I believe are the important etiological factors. One is the tight gastrocnemius muscle, two is the strain on the arch of the foot, and three is if the patient is being overweight. That's why during the MCO, we observed there was an epidemic of plantar fasciitis due to changes in people's lifestyle. Our standard treatment for such cases is to make them stretch their muscles, their calf muscles with a sloping board, and I would ask my patients to wear arch supports, both in the shoes that they wear at home, or footwear that they wear at home, and also when they go out. Surgery is indicated only in a small percentage of cases, and that is to address other underlying problems such as severe gastrocnemius contracture or even past failures. Last of all, I'd like to talk about posterior tibial tendonitis. Patients like this will present with pain along the medial aspect of the ankle as shown here. There may be a history of overuse or sudden twisting of the ankle. The medial delta ligament is not frequently ruptured due to this thickness, so I normally do not take this as my first diagnosis. However, the posterior tibial tendon is there for maintaining the arch and twisting the foot, and this is the tendon that is commonly injured. And one can confirm the diagnosis by asking the patient to do tiptoe exercises, as tiptoeing will cause pain. Again, there are a series of very good rehabilitation exercises for patients with posterior tibial injury, but like plantar fasciitis, surgery is indicated only in a small percentage of patients to address other underlying problems, such as gastrocnemius contracture or past failures. Thank you for your attention.
Thank you very much, Dr. Loh. Now we would like to open the session for any Q&A. I will have to ask Dr. Chua to answer any questions for the first two sessions. Any questions? Just raise your hand and we will pass you the mic. Okay. The mic? Raise yes.
Good morning, Mr. Chua. I would like to ask, let's say in a rugby match, and then there's a player who injured his ankle, but he still want to continue to play. So as a physiotherapy, how can we decide whether they can continue or not? Because basically most of the rugby players, they will ask us to just strap the ankle very tight so that they can still run. Thank you.
Very good question. All these players, except Malaysia, no, just kidding. I think play a game is money for them. You know. They cannot rest one. Again, they cannot rest one. They can rest when the season is on. Otherwise, rugby player is a very tough game. And they always come to you. One time I met a few rugby players in overseas. Say, which bone have you fractured? Say, no, you should ask me which one I haven't fractured. So back to your question is, do they able to weight bear? If they cannot weight bear even a few steps like Ottawa route, then they cannot play anymore. But if they still want to continue to play, they need to put on some ankle brace. They can tape on, get them to the side and tape them on. Then if they really want to play, you as a physiotherapy, you can advise them, but it's up to them, you know. But they don't have good performance, and they may damage more on their injury. But if they cannot even wait there 4 steps, forget about it. They cannot wait the ball.
But let's say if after the game they still playing, they still can continue to play after we already strap, and then after the game only he cannot bear the weight. So how can we approach them?
Okay. Suddenly after the game, everything is done, then we need a proper examination to see, or at least an X-ray, to see whether there is a fracture or not. Most of them, if they don't have fracture, especially for them very tough one, somehow their bone is more tough and they have more ligament injury or tear more than the ankle fractures. So at the time, of course, rise therapy, rest and ice. If tomorrow you want to play again, another game, and that guy is very important, and no choice, and I always ask them to wear the A60, or now they have a special new ankle brace, they continue to play.
Oh.
If they are a very important person. If they are not important, one sit inside. And I have a few gymnasts also represent state Selangor. They practice and then get injured. Of course, the tear ligament. You examine, they always say, no, I'm still not so painful, I can play, but they are in pain. If they are a really important person and they really want to continue, put in a brace, then get them on, and then see how. If they really got problem, they cannot perform. But they've been trying so many months, years,
Yes.
they want to perform. Just put on the brace, let them run, let them do, see they can do up to which level.
Okay.
So
Thank you.
normally I treat the prayer like this.
Okay.
But if they have bone fracture, there's no way they can pray.
So you can see they can even bear the weight.
Bone fracture, they cannot walk.
Good morning, John. I'm Shabis. Regarding just now, your lecture, the airboat walker, can you explain more regarding your regime post-op, maybe either post-op or conservative management in airboat walking, ankle injury, body versus soft tissue?
So if there is a fracture, for sure non-weight bearing for 6 weeks. But if there is a single metatarsal shaft or the neck fracture, there is a minimum displacement, then we can put a walker and let them have some weight bearing. But not for the fifth metatarsal and the ankle. Only for single metatarsal shaft, we can try that. Either on the second, third, or the fourth metatarsal. Right? And for the post-op, if I have the foot, ankle or the foot fixation, normally I will put them 2 weeks on the back slab for the wound to heal. And then I will change them to the walker. It's still non-weight bearing for at least 4 more weeks. Or get 6 weeks. For the soft tissue, normally I do not put them on the walker. If they are just have the lateral ligament complex injury, 90% of them do not need surgery. Right? Only 10%, if they are not good in about 3 months, then I only offer them surgery. So usually I will put them on the air sport brass. These are quite useful. But I think the latest ankle brace is quite interesting. It's I think it's more comfortable for patients. That one you can consider to put on that. Immediately for the ligament injury, I allow them to weight bear as tolerated. But always tell them any foot and ankle injury, whether it's a bony or a soft tissue, swelling for 6 weeks, for 3 months, is very common. Morning, you wake up in the morning, the foot is look so beautiful, but in the evening, too much, swollen again. Very common. So just ask them to put some ice pack again, 5 to 10 minutes, not put into the cold water for 1 hour, okay? Some people do that. So 5 to 10 minutes, put on the ice pack and elevation. When they sit down, no need to elevate until like that. Just put a low stool, they're good enough. And at night, just put 1 pillow below. That's very useful. For you, in the TCM, who is the TCM, any TCM here? Yes? Acupuncture. if you can give a good acupuncture without giving patient infection, some infection, don't mention, but if you can put good acupuncture, very good for swelling, very good. When I was in Australia, Melbourne, we work with actually the acupuncturist is the anesthetist, and he put the acupuncture 1 day after the fracture, after the surgery, or when there's a fracture, immediately we put acupuncture. The next day we can operate because the swelling can come out so fast. And I want to work with acupuncturist Chinese medicine when I was in University Malaya. I want to do research with them so that we can scientific proof, to show that acupuncture can work together with Western medicine to show that it can reduce the swelling in the acute fractures. But none of the Chinese medicine trust me. I don't know why. They don't want to work with me. I say, you come to the hospital, I pay you from the research fund. They don't want to come. So that we need the scientific proof, to show people that acupuncture is useful. Right? Any more questions? Did that answer your question?
Any more questions? Last call?
Later on, consultation.
Ask now or forever hold your peace. Okay?
Anytime you can stay, what's that mean?
Okay. Thank you very much, Dr. Chua. Dr. Chua, I would like to invite you on stage. Thank you very much. We have a certificate and a gift bag for you. I would like to invite Dr. Chung, who is the Vice President of Malaysian Association of Sports Medicine, to present the gift certificate to Dr. Chua. Please hold for photo session. And a gift bag for you, Dr. Chua. Another gift bag. Thank you very much, Dr. Chua. Thank you very much, Dr. Chua. Okay, the first session is done. We will have a short break for coffee break. You listen to the bell, we'll call you in at 10:45. Okay, 15-minute break. Thank you.